Welcome to the Deep Dive, your shortcut to being truly well-informed.
Glad to be here.
Today, we're diving deep into a topic that, well, it can challenge even the most seasoned healthcare professionals: eating and feeding disorders. How do we, as future nursing colleagues, approach these really complex conditions with both clinical precision and profound empathy?
It's such a vital question because for many people, the idea of someone, say, restricting food to a dangerous degree or engaging in self-induced vomiting,
Yeah.
it can be really hard to wrap your head around.
Right.
But these are legitimate, often life-threatening illnesses. They're not simply choices someone makes lightly. Understanding that nuance is just, well, it's key to providing excellent care.
Absolutely. So our mission today is to unpack eating and feeding disorders, drawing from a really foundational text: Roccarola's Foundations of Psychiatric Mental Health Nursing.
A classic.
Exactly. And this isn't about memorizing every single detail, but equipping you, our listeners, with the essential knowledge you need to recognize, assess, and intervene effectively in clinical practice.
And of course, nail those NCLEX questions.
Definitely those. We'll try to simplify the complex terminology, highlight the crucial assessment tools, and, connect every concept back to that holistic, patient-centered care you're all aiming to provide. Let's get started.
Okay. So we'll be focusing primarily on three main eating disorders. That's anorexia nervosa, bulimia nervosa, and binge eating disorder.
Okay.
And we'll also touch briefly on feeding disorders later, which typically show up in infancy and childhood.
So to start us off, what are the core distinctions? Like, if a nurse needs a quick mental checklist, what immediately separates these three conditions?
Okay, good question. For quick understanding, think about their primary presentation. For anorexia nervosa, the key words are extreme restriction of calories,
Okay.
an intense, overwhelming fear of gaining weight, and a really distorted body image. All of this leads to a significantly low body mass index, or BMI.
Right.
And critically, these individuals genuinely struggle to recognize just how serious their low weight actually is.
And bulimia nervosa. I know that one often gets confused with the purging type of anorexia, but they're different beasts, right?
They really are. With bulimia nervosa, the absolute key is recurrent, uncontrollable binge-eating episodes, followed by inappropriate compensatory behaviors.
So that's the vomiting, laxatives.
Exactly. Self-induced vomiting, misusing laxatives or diuretics, excessive exercise, fasting, things like that. But here's a crucial point, often overlooked. Individuals with bulimia are often at, or actually close to, an ideal body weight.
Ah, okay. That's a big difference.
Huge difference. Their self-image is profoundly tied to their body shape, and they feel intense guilt or disgust after those binges.
So the presence or absence of that significantly low BMI is a major differentiator.
Got it. What about binge eating disorder then?
Right. So binge eating disorder also involves those recurrent episodes of uncontrollable binging, eating a large amount of food, feeling out of control, but crucially, without the regular compensatory behaviors you see in bulimia.
No purging, no excessive exercise? Correct. Now, like bulimia, the binging itself triggers really strong feelings: guilt, depression, embarrassment, disgust. But because there's no purging, individuals with BED are often overweight or obese.
Which, of course, brings its own set of medical complications down the line.
Absolutely. Diabetes, hypertension, heart disease.
So while the behaviors look quite different on the surface, are there common threads underneath? Like, in terms of what causes them or puts someone at risk, what's the bigger picture?
Yeah, there definitely are shared threads. It's always a complex interplay, We see genetic vulnerabilities. There's a strong familial link, especially with anorexia, maybe around 60% heritability.
Wow, how high?
It seems so. Neurobiologically, we're looking at altered brain function, particularly involving serotonin, which impacts appetite, mood, impulse control. It's all connected.
Okay.
Psychologically, things like feelings of ineffectiveness or powerlessness, cognitive distortions, those faulty thought patterns and learned behaviors often play a big role.
Like the example in the book,
Yeah.
the teenager who loses a bit of weight and gets complimented.
Exactly. That positive reinforcement, even if well-intentioned, can accidentally kickstart or reinforce really dangerous restrictive patterns.
And environmentally, we always hear about the thin ideal.
Well, the Western cultural ideal of thinness definitely influences self-concept, no doubt.
Yeah.
But it's probably not a direct cause on its own. It's more like one piece of a much larger, more complicated puzzle. For some, especially with bulimia, there can also be links to past trauma, like childhood abuse.
It's a lot to unpack. Let's maybe focus in on anorexia nervosa first. What are the key DSM-5 criteria, And maybe more importantly, what's often the trickiest part for nurses when they're assessing these patients?
Okay, anorexia. The DSM-5 boils it down to 3 core points. You've got the significant calorie restriction leading to that very low body weight. You've got the intense fear of gaining weight or behavior that actively interferes with weight gain. But honestly, the most challenging part for nurses, and for treatment in general, is often the third point. The patient's persistent lack of recognition of the seriousness of their low weight. That disturbance in how they perceive themselves, it makes engaging them in treatment incredibly difficult.
Because they genuinely don't see the problem.
Precisely. And we classify severity based on BMI, mild, moderate, severe, extreme. Anything below a BMI of 15 kilonewton is considered extremely severe, life-threatening territory.
So as nurses, what are some of the less obvious physical signs or maybe psychosocial signs we need to be watching for? What tells us something's really wrong beyond just the number on the scale?
Good question. Beyond the obvious low weight, you need to look for signs of malnutrition. Things like lanugos, that fine downy hair, especially on the face and back.
Right, I remember reading about that.
Yeah. Mottled or cool skin, especially in the extremities. Peripheral edema, swelling in the hands and feet. Muscle weakness, constipation. Vital signs are absolutely critical. You'll typically see low blood pressure, low pulse rate bradycardia, and low body temperature.
And amenorrhea, lack of periods.
It's very common, yes, but
Right.
it's actually not required for the diagnosis anymore. Psychosocially, you'll likely observe this profound terror of gaining even an ounce, an almost obsessive preoccupation with food counting calories, collecting recipes, but not eating. Peculiar food handling behaviors, like cutting food into tiny pieces. And often, you'll see underlying perfectionism and an intense need for control.
And what about the absolute, drop everything, life-threatening complications that should set off alarm bells for any nurse?
Okay, top of the list. Cardiac abnormalities. We're talking severe bradycardia, potential heart failure, and dangerous arrhythmias. These can be fatal.
So cardiac monitoring is crucial.
Absolutely essential. Impaired renal function is another major red flag.
Yeah.
But maybe the most critical acute risk, especially when starting nutritional rehabilitation, is refeeding syndrome.
Ah, yes, you mentioned that. Explain that again.
It's potentially lethal. It happens when severely malnourished patients are reintroduced to nutrients, especially carbohydrates, too quickly. This causes sudden shifts in fluids and electrolytes, particularly phosphate, potassium, magnesium, and can lead to cardiac collapse, respiratory failure, seizures. It's incredibly dangerous. Nurses have to understand this risk and advocate strongly for a very slow, gradual reintroduction of nutrition.
That's a huge responsibility. Which brings us to acute care. When does someone with anorexia absolutely need to be hospitalized?
Hospitalization is non-negotiable for severe electrolyte imbalances, like critical hypokalemia. If their body weight drops below 75% of their ideal weight, or if they have dangerously unstable vital signs, think heart rate consistently below 50 BPM, systolic blood pressure below 90, or a core temperature below 96 degrees Fahrenheit.
Okay.
And certainly if any significant cardiac arrhythmias are present, or if there's profound depression with active suicidal ideation.
That vignette in the textbook about bathroom monitoring, it really hammered home the safety aspect for me. Can you walk us through that?
Oh yeah, that's a powerful example of the vigilance needed. So you have this 20-year-old patient with anorexia. After a meal, she asks to use the bathroom, saying she has gas and needs privacy.
Seems reasonable on the surface.
Right. The nurse, trying to balance trust and safety, agrees to stand just outside the door, but makes it clear. The toilet cannot be flushed until the nurse inspects it.
To check for purging.
Exactly. But the patient flushes the toilet anyway. That action, while seemingly small, is a significant breach of the agreed-upon plan. It immediately signals that purging might be happening, and it leads to a necessary change. A new, stricter plan involving supervised bathroom breaks for maybe 30 minutes after every meal.
It sounds strict, but it's not about punishment.
Not at all. It's a vital safety measure. It's about preventing purging, ensuring the nutrition stays in, and maintaining the integrity of the treatment plan. It highlights that constant negotiation between therapeutic alliance and safety protocols.
So in acute care, besides just keeping them physically safe and starting that refeeding process slowly, what's the main goal?
Well, establishing trust is huge, even with those necessary boundaries. You're meticulously monitoring their eating patterns, often in a very structured way. The primary therapeutic goal is weight restoration, usually aiming for about 90% of their ideal body weight, which is often where menstruation resumes. You're creating a safe, non-judgmental environment, but one that's clearly focused on normalizing eating behavior and helping them start to address the underlying feelings, the anxiety, the low self-esteem, that desperate need for control.
And what about medications for anorexia?
This is really important for nurses to know.
Hmm.
Currently, no drugs are FDA approved specifically for the core symptoms of anorexia nervosa.
Really? None.
None for the core symptoms like the drive for thinness or body distortion. Sometimes an SSRI like fluoxetine might be used, but generally only after the patient has reached a more stable maintenance weight.
Why only then?
Because the severe malnutrition itself affects brain chemistry so profoundly, antidepressants often aren't effective until some nutritional restoration has happened. And even then, it's usually aimed more at managing co-occurring obsessive-compulsive symptoms or depression, not the anorexia itself.
Okay, that's a key point. Let's try to apply this. Think about Cynthia's case study from the text. She's 20, profoundly weak, only 50% of her ideal body weight. Denies being underweight, says that classic line, "I hate it if my legs touch each other."
Right. Cynthia's objective data is terrifying. She's 62 inches tall, but weighs only 58 pounds. Her blood pressure is 74/50, pulse is 54. She's anemic. Visibly cachexic, you can see the bones she has, Lanugo. For Cynthia, the absolute priority nursing diagnosis is imbalanced nutrition, less than body requirements, no question.
And the immediate outcome goal.
Our immediate goal would be stabilization, but a key outcome for her inpatient stay would be for Cynthia to reach at least 75% of her ideal weight, which for her height is about 92 pounds by the time of discharge. That's considered a minimum safe weight for discharge planning.
What's maybe one critical nursing intervention beyond the basics of weighing and monitoring vitals that really makes a difference in a case like Cynthia's?
That's tough. There are so many crucial ones. But I think consistently acknowledging her struggle with giving up control is vital.
How so?
Instead of just enforcing rules, it's about being empathetic, saying things like, "I understand this is incredibly difficult for you," allowing her to verbalize her intense fears about gaining weight, even while maintaining the structure of the program. That helps build a therapeutic relationship.
Okay.
And alongside that, you're aiming for that slow, steady weight gain, usually 2 to 3 pounds per week, is medically safe in an inpatient setting. You're constantly using cognitive behavioral approaches, gently challenging those distorted thoughts about her body and food.
And Cynthia did make progress, right?
Yes, the case study shows that by 16 weeks, she reached that 92-pound goal, her vital signs and labs normalized, and importantly, she was participating in therapy and starting to communicate some satisfaction with her appearance, which is huge. It just shows that consistent, empathetic, structured care can work even in severe cases.
Okay, let's shift gears to bulimia nervosa. What's maybe the most common misunderstanding nurses might have when they first encounter a patient with bulimia?
I think it often comes back to appearance. These patients frequently appear healthy. They're often at a normal weight, maybe even slightly overweight. So the disorder isn't as visually obvious as severe anorexia can be.
So you have to dig deeper.
Absolutely. You need to assess for the more subtle but specific physical signs that point towards purging. Things like enlargement of the parotid glands giving a sort of chipmunk cheek appearance, severe dental erosion, and cavities from stomach acid washing over the teeth, and sometimes calluses or scars on the knuckles. That's called Russell's sign, from repeatedly inducing vomiting.
And the internal medical complications. Still serious.
Oh, absolutely serious. Gastric dilation or even rupture from binging. Esophageal tears from vomiting. And the big one is severe electrolyte imbalances, especially hypokalemia, low potassium. That can lead directly to life-threatening cardiac arrhythmias and even cardiac failure.
Wow. The shame associated with bulimia must be just immense for these patients. How does a nurse even begin to build trust when someone feels so ashamed and out of control?
It is immense. Shame is a huge component. They often feel profoundly out of control and deeply unworthy. Building that therapeutic alliance starts with empathy. Really acknowledging their struggle, their low self-esteem, without judgment.
What if you suspect they aren't being entirely truthful about their behaviors?
That's common, driven by the shame. Instead of confrontation, it's often more effective to gently acknowledge the difficulty of talking about it. You might say something like, "It sounds like this is really hard to manage, and sometimes talking about it can feel difficult too." Focus on building trust through an accepting, non-judgmental stance. Reframe the behavior as part of the illness, not a moral failing.
Makes sense. So for nursing diagnoses with bulimia, what takes priority?
The absolute priority has to be managing the physiological consequences of the purging. So problems related to electrolyte and fluid balance, and especially anything affecting cardiac function due to those imbalances, those are immediate safety risks.
And the outcomes you're working towards.
Key outcomes include the patient being able to regulate their eating patterns, stopping the binge-purge cycle. Maintaining normal electrolyte balance is critical. And then, longer term, helping them develop more effective coping skills, achieve a more realistic body image, and build healthier relationships.
Can you describe that vignette about Iris and her diuretic abuse? I thought that really illustrated the internal conflict and the physical dangers so well.
Yes, Iris's story is quite poignant. She's in treatment, weighs about 85% of her ideal body weight. As part of the plan, she stops taking the diuretics she'd been misusing.
And she swells up a bit, right?
Exactly.
Yeah.
She experiences some temporary rebound edema, which is physiologically normal when stopping diuretics. The nurse explains this, empathizes with how uncomfortable and anxious the swelling makes her feel.
That she can't tolerate it.
She just can't. The anxiety and the distorted body perception related to that temporary swelling are so overwhelming that she restarts the diuretics, despite knowing the risks. It perfectly illustrates how the psychological distress drives the physical behavior, perpetuating this dangerous cycle and putting her at significant risk for kidney damage. It shows the nurse's challenge in helping patients tolerate temporary discomfort for long-term health.
Such a tough cycle to break. For interventions, then, what's considered the cornerstone of treatment for bulimia?
The cornerstone is really interrupting that binge-purge cycle and working towards normalizing eating habits. Cognitive behavioral therapy, or CBT, is highly effective here.
And medications. Different from anorexia.
Yes, very different. Unlike anorexia, the SSRI antidepressant fluoxetine, Prozac, is FDA approved for both acute and maintenance treatment of bulimia nervosa in adults. Often it's used at higher doses than typically used for depression. Other meds might be tried too, like topiramate or some tricyclic antidepressants, but fluoxetine has the specific FDA approval.
And counseling focuses on?
A lot on challenging those distorted beliefs about food, weight, and body image, helping them develop healthier coping skills for dealing with stress and negative emotions rather than turning to binging or purging. We also do a lot of health teaching meal planning, understanding the physical effects of the behaviors, relaxation techniques, and importantly, preparing them for challenges outside the structured environment, like handling unsupervised meals at home.
Let's apply this again. Caitlin, the 30-year-old aspiring actress, she's at 95% ideal body weight, motivated to change, but terrified of being fat, feels immense shame.
Right. Caitlin comes in with orthostatic vital sign change. Her BP and pulse change significantly when she stands up, suggesting dehydration. Her potassium level is critically low at 2.7 millimole.
Dangerously low.
Extremely. Her ECG is abnormal, consistent with that hypokalemia, and she has visible erosion of her tooth enamel. For Caitlin, the priority nursing diagnosis is definitely risk for injury, specifically related to that low potassium and the physical damage from binging and purging.
And the key outcome?
The immediate critical outcome is that Caitlin will regulate her eating patterns, leading to a consistently normal electrolyte balance, particularly potassium. That's the urgent safety piece.
What's one really practical intervention for Caitlin to help break that cycle?
Well, alongside educating her clearly about the serious physical dangers of vomiting and low potassium, a really powerful cognitive intervention is teaching her that fasting actually sets her up to binge later. Many patients think restricting heavily after a binge is the answer, but it usually backfires.
That makes sense. The restriction triggers the next binge.
Exactly. We also help her explore the specific thoughts and feelings that trigger the urge to binge, and then actively challenge the irrational beliefs she holds, especially about so-called forbidden foods. Helping her slowly reintroduce those foods in a controlled way can be very powerful.
And did Caitlin improve?
Yes. The case study shows that after 4 weeks in a partial hospitalization program, Caitlin reported no binge-purge behaviors, her potassium level normalized, and she was actively working on planning meals and challenging those difficult thoughts. Progress is possible.
Okay, great. Let's move on to the third major one. Binge eating disorder, or BEDU. What's the absolute fundamental difference in the DSM-5 criteria compared to bulimia?
The crucial distinction, the absolute key, is the absence of those regular, inappropriate compensatory behaviors. There's no purging, no laxative abuse, no excessive exercise specifically to counteract the binge.
But the binging itself is similar.
Yes. The binge episodes involve eating large amounts of food in a discrete period, feeling a lack of control. And importantly, these episodes cause marked distress. They're associated with things like eating very rapidly, eating until uncomfortably full, eating large amounts when not physically hungry, eating alone due to embarrassment, and feeling disgusted, depressed, or very guilty afterward.
And because there are no compensatory behaviors, these patients are often
Typically overweight or obese, which, as we mentioned, carries its own significant medical risks: diabetes, hypertension, heart disease, joint problems, sleep apnea. The diagnostic challenge sometimes lies in distinguishing these specific, distressing binge episodes from general overeating or grazing. A careful history is key.
Given the societal stigma that still exists around obesity, how does a nurse make sure they're providing truly empathetic, non-judgmental care for patients with BED? This seems like a major hurdle.
It is a major hurdle, and it's so important. Nurses really need to engage in self-assessment here. Be aware of and actively challenge any negative reactions, biases, or stereotypes they might hold about obesity. It's vital to recognize binge eating disorder as a legitimate psychiatric illness driven by complex factors, just like anorexia or bulimia, not simply a lack of willpower or a personality flaw. That recognition is the absolute foundation for compassionate and effective care.
So what's the typical nursing priority diagnosis here?
Given the pattern of intake and often the resulting weight status, the priority diagnosis is frequently imbalanced nutrition, more than body requirements.
Okay.
Outcomes focus on helping the patient normalize their eating patterns, reduce or eliminate binge episodes, and eventually achieve a healthier target weight. Treatment is usually outpatient unless there are severe comorbid psychiatric issues or medical instability related to obesity.
Are there specific medications approved for binge eating disorder? This seems newer.
Yes, this is a significant development. Lisdexamfetamine diamsulate, brand name Vyvanse, is currently the only medication specifically FDA approved for treating moderate to severe binge eating disorder in adults.
Vyvanse. Isn't that a stimulant used for ADHD?
It is, and because it's a stimulant, there's potential for misuse, and it has side effects like dry mouth, insomnia, increased heart rate. So careful assessment and monitoring are needed. But for many patients, it can be very effective in reducing the frequency and intensity of binge episodes.
Are other meds used?
Sometimes SSRIs are tried, often at higher doses, and they might help some people, especially if there's co-occurring depression or anxiety. Topiramate is sometimes used off-label, but Vyvanse has that specific indication. However, therapy is really key too.
What kind of therapy?
Cognitive behavioral therapy, CBT, is again a frontrunner. Interpersonal therapy, IPT, and dialectical behavior therapy, DBT, have also shown effectiveness in reducing binge eating. The focus is often on identifying triggers, developing coping skills for managing emotions without using food, and addressing underlying issues related to self-esteem and body image.
Let's look at Angela's case. 25-year-old teacher, 200 pounds, long history of overeating since childhood, feels depressed, says things like, "I'll eat anything in sight," even expressing some passive suicidal ideation like, "I wish I wouldn't wake up."
Right. Angela presents with obesity. She's at 180% of her ideal body weight and significant distress, including depressive symptoms potentially linked to her eating patterns. Her priority diagnosis is clearly imbalanced nutrition, more than body requirements. But we also need to address the related ineffective coping and potential risk factors related to her depression.
And the outcome.
The primary outcome related to the BED itself is for Angela to normalize her eating pattern, reduce those binges, and work towards achieving a specific, healthier target weight according to a mutually agreed upon plan.
What's a key intervention for someone like Angela in an outpatient setting?
A really practical and effective intervention is having her keep a detailed food and mood journal. This helps both Angela and her therapist identify the specific patterns and triggers for her binge eating, what time of day, what situations, what feelings precede a binge.
Finding the pattern.
Exactly. Then, based on that, the nurse or therapist can teach her strategies like structuring and planning her meals and snacks throughout the day. Sometimes recommending smaller, more frequent meals can help prevent the extreme hunger that might trigger a rebound binge. It's about providing structure and alternative coping strategies.
And did Angela make progress?
Yes, the case notes indicate that within 4 weeks of starting treatment, including CBT and journaling, Angela was adhering to her structured meal plan about 75% of the time, has started incorporating some exercise, and had lost 4 pounds. She was acknowledging that progress might be slow, but she was engaged in the process.
That's encouraging. Okay, before we wrap up, let's just briefly touch on the feeding disorders. How are these truly different from the eating disorders we've spent most of our time on?
The main difference is they typically begin in infancy or childhood, and they're primarily about the act of feeding or eating itself, rather than being driven by distress about body shape or weight like anorexia or bulimia.
Okay, so what are the main ones?
There's pica, This is the persistent eating of non-nutritive, non-food substances, things like dirt, paint chips, paper, chalk. It has to be inappropriate for the developmental level, so not just normal toddler exploration.
And dangerous, I assume.
Very. Risks include lead poisoning, intestinal blockages, infections, dental damage. Then there's rumination disorder. This is where undigested food is repeatedly regurgitated, then re-chewed, re-swallowed, or sometimes spit out. It's not due to a GI medical condition.
What's that associated with?
It can be linked sometimes with intellectual development disorder or severe neglect, but not always. Interventions often focus on caregiver-child interaction and distraction techniques during and after feeding.
And the last one.
Avoidant restrictive food intake disorder, often called ARFID. This is where an individual avoids or restricts food intake significantly, starting usually in childhood. It leads to consequences like significant weight loss or failure to gain weight, nutritional deficiencies, or dependence on tube feeding.
But not because of body image issues.
Exactly. That's the crucial distinction from anorexia. There's no distortion of body image, no fear of fatness during the restriction. It's often related to sensory issues with food texture or taste, a past negative experience like choking, or sometimes just apparent lack of interest in eating. It often co-occurs with things like autism spectrum disorder or anxiety disorders.
Okay, that clarifies the main differences. We have covered so much ground today, from the nuances of anorexia, bulimia, and BED to these distinct feeding disorders. As we finish up, what are the absolute key takeaways for our future nurses listening? Especially thinking about ethical practice and, yes, those NCLEX questions.
I think number one is your role in empathy and advocacy. Really commit to that self-assessment piece we talked about. Challenge your own biases, especially around weight or behaviors that seem illogical. Provide compassionate, non-judgmental care, always. Remember that cultural sensitivity is key too, like understanding if fasting is spiritual or related to the disorder.
Right.
And number two, safety first. Always. Your critical role is identifying and managing those potentially life-threatening conditions.
Yeah.
The severe electrolyte imbalances, the risk of refeeding syndrome, those cardiac complications, suicide risk. That is NCLEX priority setting in action. When you see questions asking about criteria for hospitalization or which assessment finding needs immediate action, this is what they're testing.
Absolutely. And it all comes back to that holistic, patient-centered nursing process, assessment, diagnosis, outcomes, planning, implementation, evaluation. It's the framework for addressing not just the physical stuff, but the deep psychological, social, and emotional needs of these patients.
Precisely. You're guiding them step by step through an incredibly difficult journey.
Well, this deep dive into eating and feeding disorders really just underscores how vital that comprehensive nursing approach is. Remember, as you move forward in your careers, you are not just treating symptoms on a checklist. You are building therapeutic relationships, you're fostering trust, often where it's been broken, and you are genuinely helping individuals reclaim their lives from these really challenging, consuming conditions.
Couldn't agree more. It's demanding work, but incredibly rewarding. You're building both your clinical knowledge and your capacity for empathy every day.
From the Deep Dive team, thank you so much for joining us on this essential exploration today. Keep learning, keep asking questions, and keep growing into the amazing nurses you're going to be.